Hi, welcome. If you're just joining us, this is the first part of our three-part series, and I invite you to check out the other two videos. Let me begin by first introducing myself. My name is Amy Ellis. I use she, her pronouns, and I have my doctorate in clinical psychology. I'm an assistant professor and also the director of the Trauma Resolution and Integration Program at Nova Southeastern University. In that clinic, it's a training clinic. I supervise practicum students in their doctoral program who treat primarily prolonged and repeated survivors of childhood abuse, but we also see folks with myriad types of abuse. So let's get started on really defining what is trauma, and that's what we're going to capture in this video. We're going to understand what is trauma from both a conceptual framework as well as a diagnostic framework. We're going to discuss some of the limitations with that. And then we're going to really try to discern maybe some diagnostic clarification across PTSD, complex PTSD, and borderline personality disorder, and then the implications for how that affects treatment. So let's begin with understanding what is the definition of trauma. And let's also think about how we've attempted to define it throughout the years. So PTSD is the only diagnosis that we have that attempts to define a precipitating event rather than just symptoms. I'm actually going to be submitting a manuscript on this in a short while because there's some problems with that. Then we're going to lead into a discussion of big T versus little t trauma and how this is a useful framework for understanding trauma outside of the DSM. And then we're also going to be building on this and understanding some of the risk factors and unique considerations in the development of trauma and traumatization. So, trauma. Trauma refers to both an event as well as traumatization or the experience and the impact. So when we talk about trauma as an event, it could be things like combat, the Boston Marathon bombing, sexual abuse, physical abuse, emotional abuse, etc. It also refers to the experience or the reaction, which might be developing something like PTSD or dissociation or another psychological impact, depression, anxiety. So to be clear, not everyone who's exposed to a traumatic event will have a traumatic experience or be traumatized. So instead, we call it a potentially traumatic event. Every person who is traumatized needs to have been exposed to a traumatic event. In this day and age, we use the word traumatized freely, a little too loosely. I was traumatized by my boss who critiqued my work. I was traumatized when I left home without my cell phone and couldn't access social media. We can laugh at these are nonchalant remarks, but it really speaks to the ubiquity of the word and how it's really ingrained in society, but we don't really understand what trauma is. So let's start with first understanding trauma as an event. One of the ways we define trauma events is through the DSM, which stands for the Diagnostic and Statistical Manual of Mental Disorders. It's published by the American Psychiatric Association, and it's kind of regarded as this big Bible of information about all of the disorders that exists. It kind of carries the idea that if it's not in there, it's not real, it doesn't exist. We're going to talk about that. The first DSM wasn't published until 1952. And believe it or not, it wasn't officially regarded, PTSD wasn't officially regarded as a diagnosis until 1980. So 30 years later, it becomes an actual factual diagnosis, even though obviously before then, people were having these post-traumatic reactions. And as we're going to see, that definition has evolved with time and different iterations of the DSM. So for example, in 1980, our first DSM where, trauma appears, and a traumatic event is defined as existence of a recognizable stressor that would evoke significant symptoms of distress in almost anyone. That's it. Short and sweet. Nothing to it. Now we're currently using the DSM-5, and the definition now includes a lot more specificity. It's limited to events that involve exposure to actual or threatened death, serious injury, sexual violation by directly experiencing it, witnessing it, or learning about it. So this includes, but it's not limited to, rape and sexual assault, watching someone die, being in an accident, etc. We're going to come back to this in a second, though. So part 2 of diagnosing post-traumatic stress disorder is meeting categories of traumatization. And we loosely characterize these into 4 categories marked as intrusive symptoms, which could be things like recollections, nightmares, dissociation. We talk about it from avoidance symptoms, which are maybe just avoiding thinking about the trauma or avoiding different places, people, or things. The 3rd category is alterations in cognitions and mood. So having core beliefs of worthlessness or feeling as though something was all your fault in regards to the trauma. And then our 4th category is alterations in arousal and reactivity. So maybe being easily startled, maybe feeling really irritable or aggressive, and so on. So in short, to meet criteria for PTSD, which is our current standard in the US of how to diagnose someone, you would need to be exposed to an event as we previously defined it, and it has to meet a number of symptoms from each of these categories. So here we go. Let's come up with a debate here. There's a lot of debate over whether or not that definition of a trauma event is accurate and all-encompassing. First of all, as I mentioned earlier, it's the only diagnosis in the DSM that specifies you need a precipitating event. And it's not just the symptoms. So, for example, when we look at the diagnosis of depression, it doesn't tell us that there has to be a trigger, like I lost my job or I didn't do well in something, therefore I was depressed. It just says, hey, this is what depression symptoms look like. But with PTSD, we don't just look at the symptoms, we have to also include a clear definition, a very specific definition of what that event looks like. Second, the issue is that definition doesn't include things like racial traumatic stress, which is the idea that people of color are subjected to daily experiences of discrimination, unfair treatment, inadequate access to resources, and so on. But if you actually look at the research, it shows that the experience of racially charged events, not necessarily those Criterion A traumas, but still racially charged events, are associated with post-traumatic stress symptoms from those 4 categories that we mentioned before. So if we removed that first criteria of the event, folks who are exposed to this racial traumatic stress would indeed meet criteria. So it kind of makes us question whether we need to change that definition, or maybe we need to do away with it altogether and maybe return it so that it's like other diagnoses, which only include symptomatology. Ultimately, I think a more helpful framework is thinking of trauma in 2 forms. So I look at it as big T trauma, which refers to those life-threatening or sexual violation events. Those are the things we were talking about before. The Criterion A of the DSM, that's what the DSM says a traumatic event is. All right, cool. That's our big T trauma. But I also want us to think about what might be regarded as little t traumas. And these are more of the events that we regard as ego-threatening, whereas big T is life-threatening, little t is ego-threatening. Things that threaten our sense of self, our understanding of the world, others, and ourselves. There's no inherent threat to life, but these are the things that eat away at someone pervasively. We can think about how this may impact the development of race-based or minoritized identity-based traumatization, right? So having inadequate access to resources, experiences of stigmatization and discrimination, internalization of that self-hate, and so on. So if we return to that earlier example of freaking out because your boss wants to meet with you, that is not meeting the threshold for a trauma event, even for little t trauma. It really has to be strongly ego-threatening. So when we talk about the development of PTSD, there are several risk factors that the research shows us. Basically, what are the things that might make some people more susceptible to developing PTSD rather than others? We know that some people experience potentially traumatic events and their outcome is great. They go on living life and they don't develop any disorders or conditions. We also know that some people may be exposed to the exact same experience and yet they do go on to be diagnosed with PTSD. So how do we separate one from the other? How do we maybe determine what that risk looks like? So there's so many things that we know contribute to or make someone susceptible to developing PTSD. This is not an exhaustive list. But some of the things are having a female identity, having a lower socioeconomic status, having lower educational attainment, and having another diagnosis of a mental health disorder or previous exposure to traumatic events. There's other factors too, like coming from an unhealthy family environment and a family history of psychiatric conditions. People who are more likely to avoid uncomfortable or distressing emotions, they're also more likely to develop PTSD. Taken together, this does not mean that people don't experience PTSD based off of these things. Like, for example, because women experience it at twice the rate, doesn't mean men don't experience PTSD. And it doesn't mean that if someone has less than a high school diploma, they're destined for a PTSD diagnosis. We can think of it a little bit more objectively than that. Let's think critically. Women might be more likely to develop PTSD because of their minoritized status in a patriarchal society. Reduced financial status may make someone more vulnerable to situations that put them in harm's way. For example, needing to live in a neighborhood with higher crime rates, thereby putting them at risk for witnessing crime, threatened death, or assaults, and so on. So really thinking about these risk factors is more of understanding the constellation of what may put somebody in increased harm's way, as well as inadequate access to resources. We also know that if someone experiences a trauma and right after it, they don't get social support, or they're faced with additional stressors that kind of add on to it and compound it, they're going to be more likely to develop PTSD. And in fact, what we know is having social support and having people believe someone at time of disclosure can actually be really great protective factors to the development of PTSD. We're not just talking about PTSD, though. We're talking about lots of other symptoms that individuals can experience. And certainly folks may experience PTSD, or as a result of their trauma, they may experience these other disorders and symptoms. Here's the thing. We know that 55 to 90% of adults will be exposed to at least one potentially traumatic event in their lifetime. That's a lot. The modal number is 3, which means that we're really talking about in our lifetime, most of us are experiencing 3 potentially traumatic events. 34% of men will be exposed to multiple potentially traumatic events, and 25% of women will be exposed to multiple potentially traumatic events. It's a lot. Time out. Remember what I said before about how women are more likely to develop PTSD? This actually adds to our picture. It may very well be that men underreport symptoms and the prevalence rates that we have are inaccurate. That's my opinion. We know that from the research in sexual abuse of men, it can take up to 25 years to disclose trauma, if at all. So what we're seeing is that as the result of toxic masculinity, beliefs about needing to be stoic or not needing help and not reaching out for help, it's kind of unsurprising that men may not be reporting their trauma as often, and therefore their rates of PTSD aren't high. So for those individuals who have been exposed to repeated and prolonged abuse, as well as unhealthy family environments, plus the inadequate sources of social support, they might also experience these attachment disruptions, interpersonal chaos, feelings of being unsafe, either within themselves or in relationships or the world, trouble regulating their emotions, feeling empty and unfulfilled, low self-esteem, expectations of rejection. This all makes sense. Not having healthy relationships in one's life can lead to difficulties with trust, intimacy, sense of self. It also means that perhaps healthy adaptive coping skills like regulating emotions or tolerating uncomfortable feelings and thoughts were never taught to begin with. As clinicians, we might think that these symptoms are classic 100% in the DSM borderline personality disorder. It makes sense. If you look at this, the criteria for BPD, it's marked by interpersonal relationships that are regarded in black and white terms, where intimacy is really strongly attached to or devalued. BPD also has issues with identity, not knowing or feeling a sense of self, maybe even feeling those same feelings of emptiness. And so when the diagnosis fits, great. But when it doesn't, it can really affect the treatment, and it carries with it the stigma of a diagnosis that can last a lifetime. There's a better diagnosis, I think, for a lot of the time. It's just not in the DSM. Instead, it's located in the ICD-11 or the International Classification of Diseases. Complex PTSD is the same symptoms of PTSD that we talked about earlier, but it also includes 3 additional symptom clusters. You can think of it in terms of AIR. A for difficulties with affect regulation, I for identity disturbances, and R for relational impairment. Affect dysregulation means reactivity to stressors, having outbursts, maybe numbing out or dissociating. I and identity disturbances refers to a sense of worthlessness, shame, guilt. And then the relational difficulties mean having little interest in relationships and a tough time sustaining them. So if you're feeling confused, that's okay. There is a very strong overlap with borderline personality disorder, and oftentimes we haven't really known how to differentiate it, but thankfully we can turn to the research to aid in this. So what do we do when we're trying to separate out what is borderline personality disorder versus complex post-traumatic stress disorder? Well, if we actually look at those AIR symptoms a little bit closer, we see that those with complex PTSD experience a low sense of self, and it stays pretty consistent at that low range. With borderline personality disorder, there's more fluctuation, sometimes high, sometimes low. It's a little bit more fluctuated and not as stagnant and more of a state rather than a trait. Those with CPTSD tend to avoid relationships and have difficulty maintaining those relationships, particularly when there is stress in the relationship, like conflict. With BPD, relationships often take the form of being quick and intense. There's lots of ups and downs throughout. And so if we again think about it, while CPTSD individuals have difficulty with high emotions in relationships, BPD relationships are characterized by intense emotions in relationships. And then finally, when we talk about affect dysregulation, CPTSD is characterized by difficulty controlling and regulating emotions. True for BPD as well, but it tends to be more intense, and it will also include suicide attempts, self-injurious behavior, and so on. It doesn't mean that folks with CPTSD never attempt suicide or has suicidal ideation or self-harm, but it's not as intense and it's not as much a focus of what they're bringing in and discussing. So in this study by Coitra, what they sought to do is to discern between CPTSD and PTSD. And you can see both have the overlap of PTSD symptoms, but CPTSD folks with CPTSD end up having more affective instability, negative self-concept, and interpersonal problems. When those authors then attempted to look at PTSD compared to CPTSD and BPD, they found that there were actually unique profiles. So again, we have the same thing. PTSD and CPTSD, they've got flashbacks, intrusive thoughts, intrusive dreams, and so on. They've got the classic PTSD symptoms, but BPD doesn't. Where they differ is that PTSD doesn't have AIR disturbances, nor does borderline personality features. CPTSD versus BPD shows much lower scores on BPD features, except for an overlap on emptiness. So why is this so important? Well, we know that borderline personality disorder is highly comorbid with post-traumatic stress disorder, and certainly individuals with BPD do experience trauma, but BPD as a disorder and a condition is not seen as the result of a trauma. It's seen as an innate focus of who the individual is. It stays with them. Sure, we can teach skills and we can do other things to ameliorate some of those symptoms, but the predominant thought is it's with you. It's part of your personality. On the contrary, complex post-traumatic stress disorder says it's not about who you are, it's about what happened to you. And so if you're having all of these disturbances with affect dysregulation and, struggling with feelings of shame and guilt, and you're struggling in your relationships, hey, we've got a treatment for that. We can treat your trauma symptoms. We can also treat those symptoms, and we can actually help you return to a level of functioning where those are not present. So let's take a look for a second at traditional trauma treatment. Traditional trauma treatment, when we're talking about someone who just has PTSD. I know it's not my favorite language to use, but just or only has PTSD. The treatment is you expose people to the traumatic event. You repeat it over and over again until it doesn't have the same effect on you. And that's because the belief is that there's a trauma event, and then it leads to some problems in adjustment. There's the criterion A, or the trauma event, and then it leads to those 4 symptom clusters. So if we target kind of the emotional salience of that event, and we repeat it over and over and over again, by not avoiding it, by confronting it, we're going to work through it. Okay. And so when we talk about borderline personality disorder and what treatment looks like, it assumes that folks need skills for regulating emotions, tolerating distress, learning how to navigate interpersonal relationships, building mindfulness skills. But in BPD, it doesn't address any of those traumatic sequelae. So our trauma-based treatment doesn't address AIR symptoms. Our BPD treatment doesn't affect or impact PTSD symptoms. They're both kind of lacking. So when someone is chronically traumatized or exposed to traumatic stressors, what happens? So can we really actually return someone to a baseline level of functioning like our traditional trauma treatments believe, right? There's a trauma event. I'm going about life. There's a trauma event, and then I experience traumatic symptoms. And so if I work through the traumatic event, I'm going to go right back to where I was functioning when everything was fine before. Okay. But what about that person who maybe never had a healthy family environment, maybe never really had a solid baseline functioning, and then they get hit with a traumatic event or worse, multiple traumatic events that kind of compound on themselves? If we were to do traditional trauma treatment, where are we returning them to? So it kind of begs the question of maybe we need a treatment that not just focuses on exposure to the trauma event and processing it, but we also need to establish skills that perhaps were never fully formed. So with complex trauma, we're actually talking about using a phase-based treatment. And it follows 3 phases. Phase 1 is about safety and stabilization. Phase 2 is trauma processing. And phase 3 is about integration. Complex trauma requires this different response because we're trying to address the trauma symptoms and the AIR symptoms. So hear it within those 3 phases. Phase 1 is our longest and arguably our most important stage. If we're positing that it's not the trauma alone that's contributing to difficulties in functioning, but it's also a failure to having received skills that were transmitted due to a dysfunctional family environment, then this becomes foundational. It's about managing symptoms and stabilizing. This could be teaching skills for managing hypervigilance or hyperarousal. It could be about not confronting certain emotions, not, becoming more aware and more present. It's an approach that uses psychoeducation and helps people understand the impact of their trauma and kind of how it's all connecting for them. In short, you might hear a lot of those DBT skills. It's a lot of focus on those components. And the idea is we can't really move to phase 2 of trauma processing if an individual is actively using substances to cope, is experiencing stress-based hallucinations or delusions, or someone is actively suicidal, right? Like those things would certainly get in the way of confronting traumatic material over and over and over again. Instead, in this phase 1, we want to build up skills and the capacity to potentially tolerate the trauma processing that's about to occur. And we're hypothesizing, we're conceptualizing it, that those skills have never been built before. So once there's mastery over those skills and things are relatively stable, and let me make that note of, it doesn't mean that there's zero suicidal ideation, that there's zero substance use. It's not a black and white kind of idea of, okay, now we're ready to move in there, but we're looking for stabilization, that the person is functioning at a decent and well-adjusted level. Once that's attained, we can move into trauma processing. So in the first phase, we're talking about trauma and its impact on the individual, but we're not talking about it from an exposure-based place. In this stage, we're referencing exposure-based therapies like cognitive processing therapy, eye movement, desensitization and reprocessing therapy, EMDR, prolonged exposure, and so on. And so the key with this phase, particularly when working with trauma survivors, is that we continue to maintain that same level of safety and stabilization. And so these phases are not linear. We can go from phase 1 to phase 2 and back to phase 1 and phase 2 to phase 3. So there's lots of movement in there. If someone is struggling to cope with the trauma processing and they're not able to utilize those skills, maybe some of those harmful coping behaviors kind of start increasing over time. Someone blatantly tells you this is too much. Or you just see kind of reduced attendance and engagement in therapy, not doing homework assignments as part of the exposure-based assignments, or taking many vacations, etc. We don't want people to destabilize. So we want to catch that early. That tells us come back to phase 1. We need some more safety and stabilization before we revisit trauma processing. Lastly, in phase 3, it focuses on reintegrating the person into their life. A little bit of a misnomer because it kind of implies that there was some sort of baseline to return people to reintegrate them with. And for a lot of folks, it might just be integration. Oftentimes I hear from clients that they describe this process as, I didn't even know what I didn't know. Like I thought I was adulting, I thought I was living, and now I realize that there's so many things that I want to do to have more purpose in life and to find happiness and well-being. I want to move away from just survival, and I realize that this is the phase where I can really learn to thrive. So in short, phase-based treatment is about meeting people where they're at, and we'll be talking about this from a trauma-informed perspective, that it's super necessary when we're treating complex trauma in other videos. It's about maintaining flexibility around what interventions to use, when, and ultimately how to develop that strong collaboration between the client and therapist. We're unfortunately lacking a great deal of research because a lot of the materials that we have are for manualized treatments. Those trauma-focused interventions like cognitive processing therapy, prolonged exposure, we can study them real easily. You take 12 sessions and you compare it to another 12 sessions of another therapy, and we see that CPT, PE, EMDR, they're superior. But when we talk about complex trauma, phase 1 can take maybe 6 months. Phase 2 typically takes 3 to 6 months. Phase 3 could take 6 to 12 months. And oftentimes, and certainly anecdotally at our clinic, we often have clients who are with us for 2 to 3 years, so much more on the higher end. So obviously, we can't really compare a 12-session treatment to I can't even do math, 150-session treatment in that sort of way. So we don't have a lot of research out there, but what we do know is that we do have some evidence-based treatments for PTSD. We have some evidence-based treatments for BPD, and then we're starting to build up some of our evidence-based for complex trauma. So evidence-based treatments for PTSD include those ones that I shared. The American Psychological Association actually came out with a guideline for their recommended types of interventions, and those were 5. There were prolonged exposure, cognitive processing therapy, EMDR, narrative exposure therapy, and a cognitive behavioral approach. Our evidence-based approach for BPD includes dialectical behavior therapy, but honestly, anybody can be in DBT. I regard that as learning adult skills and learning how to live. So if your therapist or if a therapist recommends doing DBT, it could certainly be for a wide variety of conditions and disorders. Specifically for CPTSD, we know from the research that anything that focuses on safety and stabilization is going to be effective. That could be something like DBT, or it could be STARE, which stands for Skills Training in Effective and Interpersonal Regulation. But even better are the therapies that address the emotion regulation and the social interpersonal aspects, plus talk about some aspect of memory and processing, whether formally or informally, but processing those events and those experiences. We also know in the complex trauma literature that individual therapy is more effective than group therapy, which is interesting because a lot of times CPT and PE are adjusted to be in group format if individual isn't available. So as we come to a close and we review what we captured in this video, we discussed the various definitions of trauma and their limitations. We introduced a framework of understanding big T traumas and little t traumas that attempt to capture some of this nuance. We also discussed the importance of accurate diagnosis to inform conceptualization and treatment, particularly focusing on how BPD may act as a misdiagnosis. We reviewed the criteria for complex PTSD and the necessity of then applying a phase-based approach rather than a wholly trauma-focused, exposure-based approach to treatment. I invite you to check out some of the other videos in this series that explore adverse childhood experiences, minority stress, barriers in trauma training and treatment, and delve into some more of these concepts. Thank you.